Hi, my name is Atul Malhotra. I'm a professor at University of California, San Diego, and I'm going to talk today about the epidemiology of sleepiness in obstructive sleep apnea. I'll start out with a slide from the MEDX Cloud, which is an academic industry partnership. We published this a few years ago, suggesting about 1 billion people worldwide with obstructive sleep apnea based on existing data and extrapolations from existing data. Based on apnea-hypopnea index of 5. If you use a stricter definition of 15, we're still talking about 500 million people worldwide with obstructive sleep apnea. It turns out the minority of these patients have sleepiness. If you look at the Terry Young study from New England Journal, 24% of men, 9% of women had an AHI over 5, but only 4% of men and 2% of women had an AHI over 5 with sleepiness. These prevalence figures have increased over time because of the obesity pandemic, the aging of the population, improvements in oximetry and other technology. Bottom line is the minority of these patients actually have sleepiness. There's a major difference between clinic-based and community-based studies where the clinic-based ones tend to be more symptomatic. If you look at CPAP in terms of a therapy, it does reduce subjective but not objective sleepiness. How do I know that? In this forest plot, the Epworth Sleepiness Score consistently improves across various studies in terms of subjective sleepiness. If you look at objective sleepiness over here, based on sleep latency, really no improvement on the forest plot, suggesting CPAP reduces subjective but not objective sleepiness. If you look at this French study, they started at baseline with 602 sleeping patients. If you look at those that got one of CPAP, the Epworth went from 15 to 6. And so improvements in the majority of patients here, but still some of the residual sleepiness over here. Even the ones who weren't sleepy at baseline, some of them developed sleepiness over time. And so the bottom line here is that 58% of patients were sleepy at baseline in this French cohort, and 13% were still sleepy at follow-up, suggesting residual sleepiness is a real finding. What do we do about it? Well, full disclosure, I was involved in some of the solriamfetol studies. You do see improvements over time in the Epworth Sleepiness Score, the least squares change over here. And here's the maintenance of wakefulness test over here. Placebo shown here doesn't do much, but with low doses or higher doses of solriamfetol, you do see improvements in Epworth Sleepiness Score. You do see improvements in the sleep latency on the objective test here on the right. You see 150 and 300 milligrams look quite similar, but beyond that, you do see a dose response improvement in terms of objective and subjective sleepiness. If you look at the maintenance of efficacy over time, you can see at 40 weeks here or 52 weeks here, both in people with sleep apnea as well as in narcolepsy, sustained benefits over time. And if you look here at patients who are getting adherent or non-adherent with CPAP treatment, that is if they're using their CPAP or oral appliance, whether patients are adherent or not, the efficacy of the solriamfetol is similar. So you look at difference shown here, the patient global impression index shown here. You can see with low doses of solriamfetol, minor improvements, bigger improvements with bigger doses. Again, a dose response effect suggesting whether you're adherent or not. With your CPAP treatment, there's improvements in this global impression scale with solriamfetol. Again, sustained benefits shown here in this study, effects of solriamfetol in long-term treatment of patients with sleep apnea with adherent or non-adherent to airway therapy, that is typically a CPAP. You can see sustained benefits over time that are maintained over time, whether they're adherent or non-adherent, they're superimposable. So I'll summarize by saying sleep apnea is highly prevalent and treatment is helpful. Nasal CPAP is the treatment of choice. For obstructive sleep apnea, it works pretty well. It improves sleepiness, improves blood pressure, improves other findings. But residual sleepiness is real. So there are alternative and adjunctive therapies. Alternative therapies when CPAP's not for you. Adjunctive therapies if there's residual sleepiness, as we do see in some cases. The future is quite exciting because alternative treatments are emerging, pharmacotherapy, other things are quite exciting these days, and so it's a good place to be. I'd like to thank the audience for listening in. Thank you.